Thank you, Dr. Maitham, for
Yep.
this comprehensive and extensive presentation on COVID. I appreciate it a lot. And as mashallah, we have a very healthy presence of mostly our family medicine residents. So I think if it's okay with your permission, I present you some of their questions and queries.
Yes, definitely.
Thank you. Okay. One of the participants is having a question regarding those with acute heart failure. It seems that maybe some studies or cases where they have presented with without any fever, or patients who are previously normal, and even today I remember there was one case suddenly presented with just acute heart failure without prior fever or respiratory symptoms. What are your thoughts on that, and how is this really a possibility, and what are your thoughts on this type of presentation?
So if you don't mind, I'm going to share with you this figure from the Chinese cohort. And I want to outline this as I alluded for the fever. I don't know whether this is clear or not, but looking at this cohort, the first column is all patient. The second are the non-severe and severe, and those who develop a complication, yes or no. And I want to bring your attention to this basically. Looking at fever. Fever less than 37.5.
Dr. Maitham, sorry, you have to focus the screen. It's not showing to the audience. Currently, we are seeing the last slide.
Oh, okay. 1 second. Let me just.
Yeah. Thank you.
Okay. Do you see it now?
Yes.
Okay. This is basically the temperature distribution, and patients who are less than 37.5 that are considered to be afebrile. From all the patients, they were only 56%, which means there is 44% of patients did present without fever. And even patients who are severe, this is the column looking at severe cases, disease severity, severe cases, look at the percentage of severe cases without fever. They were 52% of the Chinese cohort, which is one of the largest cohort that was published. But during the hospital stay, on the second week of the illness, this number have decreased. So when the patient get hospitalized, fever during hospitalization, this is fever on admission. So when they get hospitalized, on the subsequent days, fever become more, and this is 38 to 39. They become 51%. 37.5 to 38 is 23%. So as I said, initially, the first 5 days, when the virus is just replicating in the cells and there isn't much of immunological response, and there is no release of interleukin-1 and interleukin-6, which cause fever, fever might not be the presenting symptoms, and they could present with a variety of symptoms and variety of signs without fever. And this is very, very important. Now, let's look at the table in terms of coexisting disorder. You see hypertension for some reason was on 1/3 of these patients, and it might be related to the fact that this virus caused disturbance in the ACE receptor, and we know how important is ACE receptor in controlling the blood pressure and blood vessels. And then coronary heart disease in around 6% of those population. So again, I'm not surprised that there is acute coronary events associated with the virus, especially if there is a change in the vascular tone when the ACE receptor is disturbed. when the cell is infected by the virus. And if you look here, obesity is not listed, again, because probably with the Chinese population, there isn't a lot of large population of the obese, but when the disease is spread to America and Australia, and in our region, obesity become one of the major risk factor, in addition to diabetes, hypertension, and ischemic heart diseases.
Okay, thank you so much for that comprehensive answer. And I think the similar explanation for, because we have one of the participants asking about blood disorders, for example, thrombocythemia or other similar blood disorders. Does that make them predisposed to more severe complications?
The answer is no, although one of the presenting symptoms, if we look at the, this is the data about the lab parameter. This is when I talked about the radiological feature. You see that in almost 2/3 of the cases, the CT scan was abnormal with a ground glass appearance. But if you look at the CBC, for example, those with severe cases presented with lymphopenia, indicating an immunological disturbance, and they had a lower number of platelets. So if the patient does have a thrombocytopenia and got COVID-19, they might be more predisposed to getting even more lower number in platelets, because again, it does cause thrombocytopenia as a virus as well. And here, when I talked about the D-dimer and the increase in AST and ALT, part of the interleukin-6 response in the cytokine storm.
Okay, thank you for that. One of the, I think you alluded to this answer, but maybe it bears also repeating. What is the latest on the role of hydroxychloroquine? I think most recent statement was that it really hasn't proven to be that effective. So I think they've removed it as a treatment modality. What are your thoughts?
Yeah, again, we have to be careful with most of the study, because the study population different between one study to another. The inclusion criteria are different. The risk factors are different. Again, it did not show a very convincing result, and it does have major side effect. Probably other supporting measures such as early ventilation, ECMO, play a major role in the healing process. And some other immune modulatory medication, such as the monoclonal antibodies and the dexamethasone, will play a major role on the severe cases. We have to remember that all these medication are considered as a priority for the patient who do have severe presentation. And those with severe presentation do have an existing underlying disease such as diabetes, renal failure, and so on. So the response to medication might be different, including the bioavailability of the drugs.
Very good. There are some, as we have most of the, as I mentioned, our residents. So I think there are some common everyday questions we keep hearing from patients and in our day-to-day practice, especially since many of us are working in the quarantine centers. One of the points that I was discussing with a colleague was how important is fever, although you did talk about it. So I think we will not talk about fever as a clinical marker. How about a practical point of using a mask post-recovery? How, in your view, important or unimportant is it to use a mask after the patient has apparently recovered? Because many of our patients tell us that they cough.
So there is two elements to this. One element is we've talked about the subpopulation of patients who are on steroid or immune compromised, that they might shed the virus beyond 10 days. So it is advisable that they wear their mask even beyond the 10 days when they leave the quarantine center, because they still might be shedding the virus, although not on a large quantity. So if they go home and they have another vulnerable person, such as their spouse with diabetes or pregnancy or whatsoever, they might take the virus to them. The other thing is, there is always the question whether a patient could be reinfected with the virus. Especially, we've talked about that not all of them will develop a good amount of antibodies to protect them in the future. And sometimes if they are really sick, if they are cancer patient, if they are a patient with diabetes and a chronic renal failure on dialysis, there is also a risk that they would get reinfection with the virus that might be severe and more severe than the first one. So we often advise them to wear masks, especially cancer patients and patients at a high risk. So it could be a protection to the society if they are shedding the virus, and it could be protection for themselves if they are from the very high risk group.
Very good. Thank you, Doctor. A point today I was also having a point of contention with a colleague was they mentioned that they've read studies of, and you've also mentioned that the fecal shedding of the virus, is it infectious? Because some studies say that it's not really infectious. Some studies debate that no, it is potentially infectious. What are your thoughts on that?
So our experience with patients with immunodeficiency, they do shed virus such as polio if they're giving oral polio vaccine. The studies are debatable whether the coronavirus is stable in the gut, or it's dead, whatever would have been infected. Most of these studies are looking at viral detection using PCR, and we know that PCR is not good for testing for fecal material, because there is a lot of inhibitory materials in the feces for the polymerase chain reaction. There is a still risk of the fecal oral route or fecal contamination. And that's why I said initially it's important to know exactly what symptoms patient does have, because this will alter your advice to them in terms of how they should take care of themselves and take a precaution for others. So although the risk is low, but it's still there. Again, it might not be of a danger to a normal population, but it could be of a danger to a vulnerable household, elderly, pregnant, people with other risk factor.
Excellent. Dr. Maitham, one of the questions is that vitamin D deficiency and its role with poor prognosis. What is your comment on that? Is it something which is worth discussing, or is it something which is real? Or
well, there is a lot of patients who do have trace element deficiency, vitamin C deficiency, D, zinc, iron deficiency, which could be an indication of a chronic disease, such as diabetes or chronic renal failure. So people just associate this with the vitamin deficiency or the trace element deficiency rather than the primary disease. Actually, the risk factor is their primary disease, the chronic condition that they do have, rather than the secondary effect of these viruses. But we all know that a lot of the cells of the immune function utilizes zinc and utilizes calcium for its function. So again, it's useful to have a normal level of these trace element rather than the mega doses. But there is no evidence that mega doses of vitamin D or vitamin C is useful against the virus. And again, I always have a trouble with vitamin D being associated with every single disease on earth.
Yes, exactly. We've seen it with almost every illness being associated with vitamin D. That is quite true. And another, this is a, let's say it's a layman everyday question. How about the items, like we've heard previously or many times, the necessity of disinfecting things which you buy from the supermarket? How true is that, or is that a myth?
Well, it's not a myth. It depends on how things are handled at the supermarket. So, if there is a good compliance with wearing the mask and proper hand hygiene, then the risk is very, very low. But if we have an ignorant people with not being compliant with using the mask and not using the hand hygiene very well, then there is a risk of a droplet dissemination on surfaces or that. Again, as I said, it might not be of a great issue for people with normal immune response, with normal immunity, but it could be of a turning point to people who are vulnerable. In general, keeping things clean is something useful. You might not need to use, as I said, it's a very weak virus. So just washing with mild soup and other cleaning agent is just enough. You don't have to use a very potent corrosive cleaning, and then you have to balance whether you are getting toxicity from those elements. But it's all depend on how much the community in the supermarket are complying with wearing the mask so they don't sneeze on items, how much they are applying good hand hygiene so they don't touch their nose and mouth and then they touch other things. So again, it does require a bit of a judgment from every person when they go shopping.
Yes, thank you. Thank you for that answer. And we also, one of the colleagues is asking a common thing, because right now, as you are aware, the one of the decrees by the Civil Service Commission of patients, certain segments being exempt. So what are your thoughts or expert opinion when you have young people, let's say young to not elderly, coming with mild asthma requesting medical reports for exemption? What do you think about that? Is it
again, I would go back to the risk stratification. We've used it generously in our employee at Beit Abdullah Hospice. We do not exempt younger people who do not have a major risk factor. Mild asthma is not considered to be a major risk factor. So again, we would counsel them that they are on category A according to the stratifications. And I would not consider this as, staying home, especially if they are in the category where they are less likely to encounter patients with COVID-19. So they are not a nurse or a physician or any allied health worker who are working in COVID ward. They are on the low to medium risk of exposure to COVID-19. I would advise all your residents to go to the New England Journal. It's a very nice article putting all the risk together in this matrix, and it's good when you talk to the patients and the employee. I'm just gonna zoom this so you can see it better, and even the advice they give.
I think the screen's on the fever on your. I think you have to change the focus of the
Yes, you're right. Okay, 1 second. I keep forgetting that this is
Yeah,
not.
it's okay because we're all getting
Uh,
used to the.
yeah. So this is the scheme basically. So
Mhm.
if they are not working with people who have coronavirus, they are on the they might encounter people who are asymptomatic or no symptoms. So they are in the low medium, so they are not at risk of getting severe disease, except if they are older than 65 years of age. What is nice about this article is also give a very clear instruction. So if you are category A, instruct the patients to wear a mask outside home, which is for all general public, practice recommended hand hygiene, and use PPE as directed. If they are category B, which means that they do have risk factor and they are from medium um, age group, 55 to 65, discuss individual risk and opportunities to mitigate exposure and to consider stopping work. Counsel patients to take all the precautions in Advise A. So maybe in this category, diabetic with renal failure, they are 55 years of age or 58, then they would be exempted if needed. If they are category C, again, they are 65 and older with the chronic diseases, and they are working in COVID ward or in emergency or in ICU, like some of the physicians we do have, then they should be counseled on a high risk from continuing to work to consider stopping work, counsel patient to take all the precaution. But this is only small segment of people that are working with people who have corona. So there are known cases of corona and you have the risk factor. These are the people who completely get exempted from going to work. So a consultant who's 70 years of age, had diabetes, hypertension, and he wanted eagerly to work in COVID ward. That is absolutely not advisable.
Yeah. Again, Dr. Maitham, thank you so much for your time. We're going to close with the last two questions. We appreciate you giving the time to us. One question is that in these times of having extra precautions with regards to patients and contact, we now see many, let's say, colleagues avoiding examination for the patients, especially, let's say, the diabetic patients, things to do with, let's say, our regular examination of foot and etc. So is it warranted? What are your thoughts on that? Do you consider that as something to practice or avoid, or what are your thoughts?
Again, I don't seem to understand the question. Can you just
means is it worth, or do you think in this day of extra precautions with the COVID infection, many doctors are avoiding examining their patients? Let's say a diabetic patient with foot exams, so they're skipping these examinations for fear of excessive contact and thus acquiring infection. So
well, I would say that this is very, very unfortunate because we are
mm,
seeing patients who are presenting with complication from their primary disease, patient on dialysis who do not go to healthcare facility, or they go to the healthcare facility, but they don't get examined very well and they come with complications. I think this is taking it to the other extreme, dealing with this patient. I think very similar to the fact that COVID-19 is a risk, other diseases might be of a risk. There are case reports of patient being missed as cancer, tumors, because of the lack of the examination. And one here should caution the limitation of telemedicine. Telemedicine doesn't mean that you ignore certain principle, but basically minimize the encounter with the patient, but not to avoid it. There is a difference between avoiding the encounter with a patient versus minimizing the encounter with a patient. So this is very, very important. Those vulnerable population of diabetes, and not only the patients with illnesses, somatic illnesses, but a lot of patients with psychiatric illnesses have been avoided going to clinics, seeing their doctors, seeking advice, or their appointment have been canceled. They do get complication from their primary illness that is way more than the risk of COVID-19.
Exactly, I fully agree. And I recently saw an article, I think, on one of the websites of the huge impact on the loss of the human touch in medicine because of the current corona pandemic. And it is quite unfortunate, as you mentioned, this human touch, which has a huge role in patient care and patient follow-up. And currently, I know it's a big problem. So, just simply wearing the mask and only seeing the eyes,
as I said, there are guidelines that are released now by many academies and royal colleges about the proper use of telemedicine and the limitation of telemedicine. So people have to weigh risk versus benefit. Maybe you can take the history, do the follow-up with the telemedicine, but at certain times, you need to provide proper clinical examination if needed. Maybe you can do the history and the follow-up via telemedicine so that you minimize the visit time in the clinic for the patient, but you should not avoid it. As I said, we should use the word minimizing the encounter rather than avoiding the encounter with the patient.
Okay. We will close with this last question. Thanks again for your time, Dr. Maitham. The question is that many patients are asking to be tested as soon as a positive contact is identified. Do you recommend referring all the contacts, including children and infants, for screening as soon as a contact is identified, as is done now, or should it rather be reserved for high-risk groups and symptomatic patients who need medical care and and may just advise for these patients home quarantine?
So there are two purposes for testing. If I can go back to my slide, 1 second. I think we are on the slide. I'm just going to show this slide. If you look at the purpose of the testing, higher priorities are for patients who are hospitalized, or a physician or a nurse who are suspected to have encountered a patient with COVID-19 and get symptoms, or residents of long-term facilities such as jail or the elderly house, dura ri'aya fi shu'un, with symptoms. So this is mostly a clinically oriented testing. But there are causes for public health reason and to minimize exposure. Again, it does require a bit of judgment. So if you have a contact and they are going to a home or a household that has a high-risk individual, then you should do testing early, as compared the risk is not going to a house that has a diabetic patient or an elderly patient. So it does require also a bit of work from the physician, taking the history, whom they're living with, what is happening, and this will allow you to pass some judgment about the urgency of doing the test. If I know that they were a contact with COVID-19 and they are going back to a house that has an elderly person who's diabetic with renal failure, probably I would advise them to take precaution and I do the testing, versus I know that these are going to a house where they're living with young parent who do not have a risk factor, then we can, negotiate whether we should do testing or not to do testing, and so on. So it does, with time, require a bit of a clinical judgment from their primary physician.
Yes, excellent, excellent. With that, we will end the webinar for today, and we would like to thank Dr. Maitham for this wonderful presentation, for giving his time, and we would like to thank all our participants, our residents, in this first of webinar series in the Kuwait Family Medicine Residency Program. Once again, Dr. Maitham, thank you so much. Jazakallah khair for this nice lecture. Hope to collaborate with you more in the future with the family medicine program. And
Inshallah.
you again soon, inshallah.
Allah yahfadkum inshallah jami'an.
Shukran. Inshallah. Thank you, Doctor. Shukran. Assalamu alaikum.